So I would like to introduce Dr. Leslie LAPPALANEN. Leslie completed a residency in family practice at the University of Ottawa in 2013, and then she completed an enhanced skills training in addiction medicine through the University of BC. She's certified by the American Board of Addiction Medicine as well. She's the medical lead for addiction medicine for Interior Health and works as a family physician at the Martin Street Outreach Center in Penticton and Ashnola at the Crossing Residential Treatment Center for Youth in Karameas. She is also a clinical instructor with UBC. So I would like to take this time to welcome Dr. Leslie LAPPALANEN.
Hi, everyone. I first just want to say thank you very much to Alex and to Monique for kind of inviting me to be a part of this conference, and I'm super excited to be here. I had a chance to meet with a couple of people this afternoon when we were doing an opiate overdose education event in Nelson. So it's very nice to be in this kind of part of the woods. Tonight, what I was planning on talking about was kind of an overview of, I need to turn my flicker on here. So an overview of the current state of addiction medicine kind of as a field of study. And then subsequently, we'll do a quick review of kind of how we define addiction. We'll look at the neuroanatomy, so the parts of the brain that are involved and some of the pathways that are involved in the brain. And then we're gonna do cases, and I really hesitate to use the term cases, but we're just gonna use a couple of examples of an individual with an alcohol addiction, and then we'll talk about some of the treatments that we've used historically, and then some of the newer treatments that we have available to us that are really underutilized. And then I'm going to spend a pretty big bulk of the section talking about the opiate overdose emergency, looking specifically at some of the numbers for the interior. And then we'll talk about some new treatment guidelines that were released in February of 2017 on the management of opiate use disorder or opiate addiction. And then finally, at the end, we'll talk a little bit about kind of opportunities for change, why some of the treatments that we currently have aren't being used, and how we might be able to fix that. So in terms of kind of the course of human history, we know that really there has always been a desire amongst humans to take mood-altering substances, and we can see this has occurred for a long period of time. Historically, we've thought of addiction in terms of several different things. So it was previously seen as having bad blood. It was seen as a nervous disorder, a brain weakness, a lack of will, spirit possession. And really, these views have shaped how we've responded as a society to addiction, and also how we've treated it. So treating it more as a moral failing as opposed to a health problem. So this is a journal article that was written almost 100 years ago, so in 1919, and the author of this paper, his name was Ernest Bishop, and he wrote about addiction as a disease that required treatment instead of criminalization. And he called for a revolution to really wake up physicians and the public, that we need to be educated to see addiction as an illness and really treat it as such. And unfortunately, we are very close to being 100 years later, and we're having very similar conversations. So in terms of where we're at in understanding addiction, over the past several decades, there's really been enormous investments in terms of addiction medicine research. So in the US, there's a large organization called the National Institute on Drug Abuse. So the National Institute on Drug Abuse, their annual budget for addiction medicine research is $1.5 billion a year. So we've been studying this for a quite long period of time. In Canada, we have an organization called the Canadian Centre on Substance Abuse, and we invest $7 million annually on substance use epidemiology and research. So in addition to this, there's a large number of federal research grants that fund addiction medicine research. There are very regularly publications in some of the most reputable medical journals in the world on topics related to addiction medicine. So, for example, in JAMA, which is the Journal of the American Medical Association, in the New England Journal of Medicine, in the British Medical Journal. In addition to this, there's a large number of peer-reviewed journals whose primary focus is publishing research on addiction and its treatment. And unfortunately, in many settings, despite having this really large body of evidence to support the way that we should treat addiction and how we should treat it as a medical condition using science-based therapies, we often don't. So we continue to frame addiction as being a choice and associate it with being weak. And there really is, in my mind, no bigger area of medicine where there's a bigger gap between what we know scientifically and what we're often doing in practice. As many of you will be well aware, we continue to treat addiction as a criminal issue rather than a medical one. And what we've learned from the war on drugs is really it doesn't work. It's not effective in terms of decreasing drug use. It's not effective in terms of decreasing drug trafficking, but it is a really expensive way to try and address it. Increasingly, there is some political recognition that criminalizing drug use isn't effective. I'm hoping that with President Trump, things won't go really backwards. So Obama was pretty good at advocating for this. We will see with Trump how that goes. So in terms of how we define addiction, there's many different definitions that you could use. I really like this definition. So this is from the American Society of Addiction Medicine. And they define addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. And it's dysfunction in these circuits that leads to characteristic biological, psychological, social, and spiritual manifestations. It's further characterized by an inability to abstain, impairment in behavioral control, craving, a diminished recognition of significant problems that it causes, a dysfunctional emotional response, cycles of relapse and remission, and this is similar to what we see in other chronic diseases, and we'll talk a little bit about that. And then without treatment or engagement in the recovery process, it can result in disability and premature death. And certainly I think the opiate crisis has really highlighted that. How we clinically diagnose an opiate use disorder or any type of substance use disorder is using something called the DSM-5. So essentially, over the last couple of years, this has shuffled a little bit. We used to use the DSM-4, now it's the DSM-5. I didn't change the slides again. There we go. So these are the 11 criteria that we use, and you can see that they're kind of broken. You can kind of subcategorize them into criteria involving impaired control, criteria involving social impairment, criteria involving risky use, and then pharmacologic properties, so things like tolerance and withdrawal. Essentially, when we're diagnosing an opiate use disorder or any type of use disorder, we look at these criteria and we determine how many criteria an individual meets. Depending on how many criteria, their substance use disorder can be ranked as either mild, moderate, or severe. Clinically, it's sometimes kind of hard to remember 11 criteria when you have a person in front of you. So this is kind of the simple version. Lack of control, And this is something that you see quite commonly. For example, an individual with an alcohol use disorder or alcoholism, often they want to be able to drink socially, but what they find is once they have that first sip or that first drink, they're not able to control their use, so it results in consumption of way more than they intended to use. Compulsion to use. And then consequences. And this is really the crux of addiction, is having negative consequences and then using despite those consequences. And those consequences can take a number of forms. They can be occupational consequences, so not showing up from work, or not being able to go to work because you're too hungover, getting fired from work, etc. They can be relationship consequences, so getting in fights with your partners, your kids are upset that you're not as present as they would like you to be, etc. They can be medical consequences, so for example, for someone with a nicotine addiction, so a smoker who gets diagnosed with COPD, they're advised to quit smoking, but they continue to smoke. Or having been diagnosed with a cancer or heart attack and continuing to smoke despite that. And then finally, craving and preoccupation to use. So that's actually a new criteria that was added in the DSM-5 that wasn't previously included in the DSM-4. So who's at risk? Like other chronic diseases, there are certain risk factors that place individuals at a higher risk of developing disease. So in terms of biological risk factors, we know that up to 50% of addiction risk is related to our genetic profile. Additionally, there's environmental factors such as exposure to what are called adverse childhood experiences that place individuals at an increased risk. And these include a number of things, so things like witnessing domestic violence, facing various types of abuse or neglect, parental separation, incarceration of a loved one, substance misuse within the home. And essentially, the higher number, an increased number of these types of experiences in childhood places an individual at increased risk of developing an addiction. Additionally, there's factors such as one's peer groups and then their attitudes towards drug and alcohol use, as well as availability of the drug, put certain people at an increased risk. And finally, there's risks involved with the kind of inherent in the drug itself. So how rapidly it reaches the brain. So essentially, the faster it reaches the brain, the more addiction liability there is. And that can relate to the drug itself and the mechanism of how the drug works. And then it can also relate to the route. So we know that if a drug is taken orally and it's absorbed through the intestines and then reaches the brain, that results in a much slower release of something called dopamine, which I'll talk about shortly, than if someone smokes a drug or someone injects a drug. That results in a much more rapid release of dopamine. This is a view of your brain. It's called a sagittal cut, so it's like if I cut my brain like this and opened it up. So this is on the left-hand side of your screen, that's the front of your brain. This is the back of your brain. And I'm gonna highlight in a kind of simplistic way 3 important structures that are involved in what are called the dopamine pathways in the brain. And these are, the other name that you'll hear for them are the reward pathways in the brain. So the first area is an area called the ventral tegmental area, or the VTA. And essentially what this area does is it produces something called dopamine. Dopamine is like a chemical messenger between nerve cells. So this area, the VTA, produces dopamine, and then it sends it over to this area called the nucleus accumbens. When the nucleus accumbens gets dopamine, it's associated with a feeling of reward or pleasure. So you get dopamine, you're like, whoa, that felt good. It's also involved in memory and kind of goal-directed behavior. So it helps you, when you get a little kick of dopamine, it is involved in remembering what that activity was because it felt really good. The other area that the ventral tegmental area, so that first area that I was talking about, sends messages to, is an area of the brain called the prefrontal cortex. The prefrontal cortex is involved in impulse control, and we know in addiction, this part of the brain can become impaired. So why do we have these reward pathways in our brain? Our brains have adapted to essentially have mechanisms to reward or repeat activities that are important for our survival. So things like eating food, having sex, drinking water, hugging your kids are all things that we need to do in order to survive as a species. And so our brains have learned ways to make those activities feel pleasurable so that we repeat them. Does that make sense to everyone? Yeah. So all drugs with kind of addiction potential use this same circuitry. So exact same mechanism, but what happens is they can result in a release of dopamine that's between 2 to 10 times the amount that is released with natural rewards like food or sex. So it's bigger kind of dumps of dopamine when you use drugs. Because this kind of effect on the brain is so strong and so powerfully rewarding, it often motivates people to continue to use these substances because our brain is telling us this feels really good. So what we see is over time, people may begin to change their behavior such that they kind of reprioritize the use of drugs or alcohol over things that they would have otherwise gotten a lot of pleasure out of. So that may be kind of satisfaction from work, hugging your kids, spending time with your family, having sex, even food. We know that lots of people don't really look after themselves when they're really in their addiction, so they may not eat for periods of time. And that's because their brains have changed as a result of the drug use. So just to quickly review, natural rewards for things, our reward pathways in our brain result in kind of little kicks of dopamine to reward things that are important for our survival as a species. So things like eating food, having sex, drinking water. Drugs of abuse use this same system, but result in much larger kind of releases of dopamine. And each drug uses a slightly different mechanism on how it gets more dopamine there. That doesn't really matter. Just know that there's more dopamine available. What we see is, as you continue to use repeatedly, your brain gets, our brains and our bodies are always trying to maintain something called homeostasis, so kind of to even things out. So if your brain gets these big kicks of dopamine all the time, what it does is it starts to down-regulate your dopamine receptors. So there's fewer receptors in your brain. And we can see that on neuroimaging. This is more of a research thing. This isn't something we do clinically. It does come back. I have a slide coming up on it, but it does resolve. So we see that in the healthy control there, the red is a high concentration of dopamine receptors, and you can see that this, I don't know how long this person has been using drugs, but they have a lower concentration of dopamine receptors. And that's our brain's way of trying to adapt. So we see these brain changes occur. This diagram I really like. And it shows the course of someone, kind of a fairly typical course of someone during their addiction. So we see when someone first begins to use substances, they're using and they're getting that euphoria. So they get that big kick of dopamine, their body really likes it, they get that euphoria. And as they continue to use, those dopamine receptors start to downregulate. And so they end up using more so to feel normal. So you can see that white squiggly line, they're getting euphoria, And then at a certain point, if they're not using, they're in withdrawal, they feel anxious, they feel depressed, and then they're using just to get in that normal range. And that's why you'll hear lots of people say, I hate my drug use, but they feel tied to it, and they're only using to get themselves out of withdrawal and to get themselves feeling normal. we try to do with certain types of addiction, and opiate addiction is really the prime example of this, is we try to use medications to get people back into that normal range, so they're not having those peaks and troughs of euphoria and withdrawal. So just to feel normal, where they can go to work, go to school, and not have to think about using all the time. The brain changes that we see with chronic drug use are similar to other organ changes that we see with other chronic diseases. And when we kind of understand and treat addiction as a chronic disease, similar, I'm a family doctor, so I see people with addictions issues, but I also see them for their asthma and diabetes and high blood pressure and other things. All of these disease processes have periods of time where people may have their disease under pretty good control, and then they may have periods of kind of relapse where we need to intensify the treatment. And really what a relapse in a person with a substance use disorder should mean is that we need to intensify the treatment to further support them, or we need to change the course of the treatment if the current treatment plan isn't working. Here's the slide I was talking about. So the encouraging thing is that the brain does recover. It takes time to recover. This 14 months is not the time period that the brain needs to recover, but essentially the longer periods of abstinence that you have, the more likely you are to remain in sustained remission. So once you've reached 5 years of abstinence, you're pretty back to the average risk in the population. And I think that this slide says that. So after 5 years, you'll probably stay that way. So if you get to 5 years, that's a really good indicator. So just to kind of review what we've talked about so far, addiction is a chronic brain disease that affects the reward pathways in our brains. Drugs of abuse, so drugs with addiction potential, be it nicotine, alcohol, heroin, fentanyl, crystal meth, cocaine, they all result in spikes or surges in dopamine that are greater than those produced by natural rewards. With repeated use, our dopamine levels downregulate, and this is kind of why we see what's called tolerance, so someone using more drug to get the same effect. That tolerance can also result in people using drugs just to feel normal or to keep themselves out of withdrawal. In terms of what I think is really the good news is addiction is treatable, and the brain changes that we see are reversible, but they do take time. And addiction is kind of not unlike other chronic diseases that we treat. It does require chronic disease management, and historically I don't know that we've always treated it that way, that we've said like, okay, go to detox and you'll be fine, or go to a 28-day treatment program and then you're probably fine. Really what the research shows is that we need to treat it as a chronic disease. And so there's some areas for improvement that way. And then what I'm gonna talk about next is just looking at alcohol use disorder or alcoholism, and then looking at opiate use disorder. So first, in terms of alcohol, this is kind of a busy slide, I apologize. Globally, 2 billion people worldwide consume alcohol, and it causes a lot of harm. So about 5.9%, almost 6% of all deaths globally were attributed to alcohol consumption, which is pretty huge. If we think of overall the harms related to substance use in Canada, the majority is actually alcohol and tobacco that are killing people, not illicit drugs. So this is important to keep in mind. Within Canada, 23% of those who drink had an episode of what's called heavy drinking, so drinking more than 4 drinks in one session for a woman, or more than 5 drinks for a male. And about 4% of the population met the criteria for an alcohol use disorder or kind of alcoholism. We know that in terms of alcohol, there's kind of a dose response curve in terms of harms. and people are affected in terms of health harms from alcoholism, but also from a number of other harms. So drinking and driving, impact of alcohol on a fetus, for example, if women are drinking while they're pregnant, injuries such as people falling down the stairs, etc. So there's lots of health harms from alcohol. The case that I'm going to talk about is, has anyone seen the CBC documentary called Wasted? Yeah, some people? Okay, so it's a documentary. It's available free online, and it features this gentleman named Mike Pond. And so Mike was a psychologist working in Penticton who struggled with alcohol addiction, and he is kind of the feature of this documentary, and he also wrote a book called Wasted about his experience. And when he was seeking help for his alcohol addiction, he was told repeatedly to attend an AA, and what he found was it didn't really work for him, and then he felt a lot of shame that it wasn't successful. So kind of everywhere he went, they're like, "Did you try AA? Go to more meetings," and it didn't work for him. So eventually he ended up homeless. He was living in the downtown east side, was really struggling with his alcohol addiction. He was able to get on a medication option for alcoholism, and fortunately has done since quite well, and is really passionate in public speaking and advocating now for the compassionate treatment of people with addiction. And so I just thought this little kind of snapshot about his experience would be kind of a nice segue in terms of talking about just the treatment options that we have for alcohol addiction. So I'm sure most of you guys know about 12 steps. So AA was a group that was started in the 1930s by a man named Bill Wilson and a physician named Bob Smith. They were both alcoholics. Wilson attained sobriety largely through his affiliation with a Christian movement. And then Smith stopped drinking after he met Wilson, as he was inspired by his success. And together they published a book which now kind of spells out the philosophy and principles of what is known as the 12-step method. And in AA, members meet in groups. They help one another achieve and maintain abstinence. The meetings are free and open to anyone serious about stopping their alcohol use. And people are encouraged to kind of integrate the steps, to work through the steps and integrate each step prior to proceeding to the next. So opinions on AA are really mixed. So you'll hear things like this, and then you'll also hear things like this. So I'm not going to go through all the literature on it, but what the literature shows is that AA really works well for some people, probably about 30% of people with alcohol addiction. There's no question that it saved probably hundreds of thousands of lives. But it doesn't work for everyone. What the research shows is that the people that really fully participate and provide service seem to benefit from AA the most. There is evidence showing that forced or coerced AA really doesn't work very well, and it doesn't work for everyone. This is a quote from the founder of AA, who said, "Please know that we, as AA, hold ourselves ready for scientific investigation, and that we fully realize that we are but a small part of the total effort going on in this broad field, and so is to aid where we can." And so I think it does play a really important role. It's just that this isn't the only treatment option or the treatment option that works for everyone. So what are the other tools that we have to treat alcohol addiction? So there's really good evidence looking at treatments, including what's called cognitive behavioral therapy, which teaches kind kind of skills to learn better coping with situations that could commonly trigger relapse, motivational enhancement therapy, which is designed to kind of boost motivation to cease problem drinking. There's also pharmacotherapy options. So in Canada, there's 3 Health Canada approved medications that are all really underutilized, but I would say especially the top 2. So there's a medication called naltrexone, which is a once daily pill. I have a couple more details on it. A medication called acamprosate, which is a medication that you take 3 times a day. And then there's actually a lot of ongoing research looking at what are called off-label uses of medications that currently are available. So there's a medication called gabapentin that we use mainly for nerve pain. It's an old anti-epileptic medication. And it has some really good research for alcohol use. Topiramate is a medication that we use, also was an anti-epileptic. Baclofen is a muscle relaxant, and ondansetron is a medication that we use for nausea. And all of these medications have ongoing research that's quite compelling, looking at their use for alcohol addiction. So I'm going to very briefly talk about the 2 Health Canada approved medications. I crossed out antabuse, which is often the only medication people have heard of. So it's a medication that works by blocking one of the enzymes that's involved in alcohol metabolism. And so you get a buildup of this metabolite of alcohol that makes you feel terrible. So if you drink on top of it, you get flushing, you feel nauseous, you just feel awful. And what the research shows is it works okay in settings that, like for example, if a nurse had an alcohol addiction and to keep their job, they had to take this medication every day, and someone was watching them take it, it may work okay in those types of situations. But most people that are on it, they just plan to stop taking it. And then they're like, okay, I'll take my medication Monday, Tuesday, Wednesday. By Friday or Saturday, I should be able to drink. So realistically, in real world settings, it doesn't work that well. I also would say there's no other area of medicine where we punish people. So if you have diabetes, I'm not going to give you a medication that is going to make you vomit if you eat a donut. And I don't think that we should do that in addiction. So the 2 medication options that are Health Canada approved, naltrexone and acamprosate, don't make you feel sick. And that's the first thing I always tell all my patients is it's not the one that's going to make you feel sick. Because that's often the only one people have heard of, and they're like, I don't want the medication. So naltrexone, I'm just going to have a sip of water here. Naltrexone is an opiate receptor antagonist or opiate receptor blocker. It sounds very similar to naloxone or Narcan, and it works in a very similar mechanism. So it works exactly the same. It's just a pill that lasts longer, so it's not an injection. That's the only difference. So it's a pill that you take orally, and it has good oral absorption, whereas naloxone, like Narcan, doesn't have good oral absorption. That's why if someone overdoses, we give them an injection. Or like there's a nasal spray. We don't put it under their tongue or make them swallow it because it doesn't absorb very well. So with this medication, it's a once daily medication. It blocks some of the euphoria or some of the kind of high that a lot of people like, especially binge drinkers. So they really like that really drunk feeling, and it blocks that euphoria, doesn't make you feel sick. It can be used as a harm reduction tool. So I have quite a few patients where their goal isn't abstinence, and we use this medication to decrease the amount that they're drinking. And for some people, it works beautifully. So we have one guy at our clinic who is a non-beverage alcohol guy, so he's drinking rubbing alcohol and other things. And we would give him a cigarette, which I don't like the cigarette incentive, but in terms of overall harms, we'd give him one cigarette if he took his naltrexone. And for him, He drinks way less when he still drinks throughout the day, but he drinks way, way, way less, and he ends up in emerge way less. And so it's a way to kind of mitigate the risks for him. And overall, he's much more stable when he's on this medication. The research body for the use of these medications is actually really, really good. So in medicine, we use something called the number needed to treat. And this is how many people do you need to treat with a medication to prevent whatever your outcome is. In alcohol, to prevent a heavy drinking day, which is a drink, more than 4 drinks in one sitting, for a woman 5 drinks in one sitting for a male, the number needed to treat is 9. Say most medications that we use in medicine, if we get a number needed to treat of like 25 or 30, it's gold standard, we use it all the time. So these are really amazing numbers, and we don't use these medications very often. So this medication seems to work best for decreasing the number of heavy drinking days. Yeah. I have, and I've been looking for good research to show, the question was using it for what's called the Sinclair method. So most of the literature that looks at naltrexone looks at it as a once daily medication. But there's something called the Sinclair method where people take it just prior to drinking. So for example, people who don't drink every day, who binge drink, you take it 30 or 60 minutes before drinking, and they seem to drink much less. I have one patient that's doing it, and she would get into lots of trouble when she's drinking. And if she takes it, she can have like 4 drinks and go home and doesn't get kind of blackout drunk, and seems to work well for her. I haven't been able to find good research comparing the 2 methods, but anecdotally it seems to work well for lots of people, and I know lots of people use it that way. The other factor is cost for some people. So there is something called the collaborative prescribers agreement that physicians sign, and they'll get these medications covered. But if you have a pharmacare deductible, you still have to pay up to that. And it can be quite expensive. So it can be over $100 a month. So it's a pretty pricey medication. So for people who are paying for it, especially if they're not a daily drinker, the Sinclair method seems to make sense to me. Or they could even take it if they're having a craving, take it. You're welcome. The other medication is called acamprosate. I don't know why the producers made it in 333 milligram tablets that you take 2 of them, so it's 666, 3 times a day. Not sure why they did that. I always tell my patients that in advance. If they're a little paranoid about me before, they're more paranoid after I give them this. Generally, we start this medication when someone is abstinent, but it can be started prior to. The product monograph suggests 3 or 4 days abstinent before. Again, the research for this medication is really, really good. It's stronger for abstinence. So in people who don't want to drink at all, we tend to choose acamprosate. And this was an article published in JAMA in 2014 that showed that fewer than 1/3 of patients with an alcohol use disorder actually receive treatment for it. And only a really small percentage, so less than 10%, were offered medications to help in reducing their consumption. So despite having really good evidence, like the numbers needed to treat are outstanding. And we don't use these medications, or they're not routinely offered to people. I mentioned gabapentin earlier. There's some really interesting research looking at gabapentin for alcohol use disorder. And the research shows a really nice dose response in terms of decreasing heavy drinking days, increasing rates of abstinence, but also decreasing cravings and improving sleep. And we know that cravings and poor sleep are a reason why a lot of people relapse. So interesting research looking at this. There is some street use of this and kind of misuse of gabapentin, and so that is something that we have to be cognizant of. And then in the US, I had mentioned this medication called naltrexone. So it's the opiate receptor blocker, the once-a-day medication. In the US, there's an injectable form of this medication. And so it's a once-a-month injection. It's not yet available in Canada, but may be a treatment option that will be coming in the future, but not yet available. So just to review, kind of in our toolbox of options for alcohol addiction, we have more than just AA. So if AA isn't working, or someone's like, I don't want to do AA, don't say AA, we've got all these other things that we can try. And really we should treat addiction, I'm going to sound like a broken wheel, but we should treat addiction like we would other chronic diseases. So if I have a patient who has a new diagnosis of diabetes, we may try lifestyle management initially. So that means changing their diet, exercise. I'm going to reassess them in several months and then check in and see if it's working. If it's not working, I'm going to change the plan. I'm not going to say do more diet and exercise. I'm going to change the plan and say, like, okay, this hasn't worked, so what else can we do? And I might refer them to a diabetes nurse educator. I may start them on a medication. I'm going to wait a period of time, see if that works. If it's not working, then we're going to change the plan again. So we're going to intensify the treatment. And we should be doing this with alcohol addiction and any type of addiction. So if someone comes in and they're like, oh, I tried this and it didn't work, we shouldn't say, try it harder or do more of it because you just haven't been doing enough of it. We would intensify the treatment. And that's, in my mind, what we should be doing with addiction. So we'll shift gears and we'll talk a little bit about opiates. This, I don't know, does everyone know what opiates are? Yeah. I'll go over a very brief overview. So essentially opiates are just substances that bind to opiate receptors in our brain and produce morphine-like effects. They're mainly used as pain relievers or analgesic medications. The side effect profile of all opiates is actually quite similar. So can result in sedation, nausea, constipation, euphoria, depending on the route and how quickly it acts, and then respiratory depression. And I underlined respiratory depression there just to highlight that all opiates naturally decrease what's called our drive to breathe, so that natural instinct to take a breath. And what occurs in an overdose is that people take more than they have tolerance for, and their breathing slows to a point where they can't sustain life. So their breathing slows to less than a couple breaths a minute, and they can't oxygenate their tissues, and they can't oxygenate their brain, and so that's how people die. So that's what opiates are. These are headlines that I'm sure you are very well accustomed to seeing now. So over the last really 2 years, we've been hearing about this rise in fentanyl and this opiate overdose emergency. So in April of 2016, Perry Kendall, the public health officer for the province, declared a public health emergency as a result of increasing opiate overdose deaths. And what a public health emergency means is that we can mobilize more resources more rapidly to make changes to prevent harm. So in a little bit, we'll talk about other public health emergencies and how we've responded as a healthcare system and how that compares to this public health emergency. So opiate overdose deaths now exceed car crash fatalities in BC. And this is a quote, I don't know if you guys can read that, from Jean Philpott, who's the Canadian Minister of Health, who was at the Harm Reduction Conference in Montreal last week. And what she said was, we know that at a minimum in Canada, there were 2,300 Canadians that died last year of an opiate overdose. And this death toll is worse than any other infectious epidemic in Canada, including the peak of AIDS deaths. And since the Spanish flu that took the lives of 50,000 people a century ago. When we look at the numbers, so this is from the BC Coroner's report, and this was a report published in kind of mid-April of 2017. What you're looking at here is the blue bars are the number of overdose deaths per year. So it goes from 1991 on your left there up to 2017, and this includes just January, February, March for 2017. So you can see in total in 2016, there were 931 overdose deaths. And then we're gonna look more specifically at 2015, 2016, and 2017. So you can see over the last couple of years, there's just been skyrocketing in terms of the number of overdoses. So when we kind of zoom in on 2015, 2016, 2017, I just wanted to highlight that despite this public health emergency being declared, and us really as communities, as a healthcare system, trying to improve access to treatments for opiate addiction, overdose prevention sites popping up in some larger communities, there is no sign that this is slowing down. And if anything, the death rates are going up.
They've doubled.
Exactly. So if we look at March 2016 compared to March 2017, in March 2017, there were 120 overdose deaths in BC alone for that month. So 4 people dying every day. Yeah, it's crazy. And this is really just to highlight that we're on track for the worst year yet. This is largely related to an increased amount of fentanyl being mixed into the illicit drug scene, and we'll talk about that in a little bit. And this is just to demonstrate kind of overall patterns across the province. And I'm gonna go through these really quickly, but essentially the legend is over here. The darker red it gets, the higher the death rate per 100,000 people. So this is 2010, 2012, 2014, and 2016. And often when we hear about this opiate overdose emergency in the media, a lot of the kind of focus is like, this is occurring mainly in the downtown east side. It's mainly a Vancouver problem. And what this data is looking at, I want you to look, oops, I wasn't supposed to do that yet. Look at 2016, and this is the death rate per 100,000 people. And so you can see Vancouver Coastal Health is 21.6, so it does have the highest death rate in the province, but Interior, we are like almost the same. So we're really, really, really close to that. And so we've got a lot of work to do to decrease this. When we look at the number of overdose deaths broken down by community, what we see is there's a number of communities in the Interior that have really high numbers. So Kelowna and Kamloops, and then Vernon is pretty close behind there as well. No, Penticton's its own, yeah, its own kind of area. So Penticton's not quite there yet, although I've heard from the coroner that works in Penticton that some of the deaths aren't being coded properly. So they're being coded as like respiratory arrest secondary to lifestyle choice, not coded as an opiate overdose. So I think in the coroner's data, it ends up, because it goes to the coroner, it ends up getting coded properly, but that's not really how we should be coding these deaths. It kind of, in my mind, it's important that we report opiate overdoses that are occurring and that they are coded correctly, because it also, like, you can see that Kelowna and Kamloops have had the highest numbers, and this is why some, as a health authority, The resources that we're allocating to certain communities are based on the number of overdoses that are occurring and the number of deaths in the community. Because we don't have resources to set up supervised injection sites currently in every community that needs it, because probably every community of a kind of certain size could benefit from one, but we don't currently have the resources to do that, so we have to really select like which communities need it the most at this point, unfortunately. So those are really tricky decisions to make, and it's based partly on this type of data, so coding the data correctly is really important. Just in terms of other public health emergencies, could people, like if you think the last 15 years, what are some public health emergencies that we were, as a health authority, really kind of worked up about? SARS, what's that? H1N1, any other, there's one other one that occurred a couple years ago. Ebola. So if we think of kind of those, so SARS happened in 2003. When we look at overall in Canada, there were 44 deaths from SARS, 400 people ill. H1N1, 400 and some people died in Canada, 56 people died in BC. Ebola, there was a lot of attention about that. No one died, no one was ill. We look at opiate overdoses. So just looking at BC, and this data actually needs to be updated, so it's actually 931 deaths, 30,000 people who are ill, and this data was taken from opiate overdoses that were non-fatal. So 30,000 non-fatal opiate overdoses. And then when we look at interior health specifically, 154 people who have died in 1 year alone. So this is really, in my mind, compelling data that I don't think we've responded with the same kind of intensity that we have in other public health emergencies. Reasons for these overdose trends. Overprescription of opiates is a huge factor, and we'll kind of go through that. And then certainly impurity of the drug, so increasingly fentanyl being mixed in the drug scene. When we look at over the past couple of decades, we see that there's been a dramatic rise in the number of prescriptions for opiates, both in Canada and the US. So Canada is second only to the US in terms of highest number. This is American data. We're second only to the US in terms of number of opiate prescriptions. And there's nothing that I think makes any clinical sense that Canadians have way more pain than people in Europe or other countries. So I think chronic pain exists lots of places, but we're treating it with lots of opiates. So part of this is partly due to some marketing or physician education that was done by Purdue Pharma when this product called OxyContin was released. So OxyContin is a long-acting formulation of a opiate called oxycodone. And physicians were kind of taught that really we're under-treating pain. Pain is the fifth vital sign. If someone has pain and we give them opiates, they're really at low risk of developing addiction. So we should be kind of more liberal in prescribing these medications. And I think as a physician, like when you're told that and you have someone in front of you that's in pain, like we went into this field because we want to help people. So we're like, okay, well, this dose didn't work, so we'll try increasing the dose. And then we just kind of increased and increased and increased. And what we saw is, since this physician education kind of occurred, the amount of opiate prescriptions for this medication in particular, this is American data, increased substantially. So in 5 years, it went from 670,000 prescriptions to 6.2 billion, or million rather. And what we learned after was that OxyContin is really highly addictive. So despite it being a long-acting medication, it's easy to abuse it, and make it a short-acting agent. So if it's snorted or injected, it takes away that long-acting kind of capability. And so in 2007, Purdue, the makers of OxyContin, pleaded guilty to misbranding the drug's abuse potential and paid $600 million in fines. And when we look at kind of overall, we see that as there's been a rise in prescription opiate sales, that's been mirrored by opiate-related deaths, as well as admissions to residential treatment facilities for opiate addiction. This is kind of outdated, actually. I should have taken this out. So initially, a lot of the fentanyl that we were hearing about in the illicit drug scene was being produced in China. And more, we think it's being produced in Canada as well. So ignore this, I should have taken that out. But the amount of overdose deaths is largely attributed to fentanyl being increasingly mixed into illicit drugs. And fentanyl is really powerful for a small volume, for a small amount. And it's cheap to produce. And so that's why it's being mixed in, is you can get away with like a couple little bits of fentanyl, and it's way easier to import or to traffic fentanyl than it would be an amount of heroin or cocaine or other drugs. So that seems to be the rationale for using it, is its ease of trafficking, and it's cheap. So how do we stop this overdose trend? Really, it takes a bit of a paradigm shift from what we have been doing for opiate addiction to, in my mind, a better application of the evidence we have on how we need to treat it. So this is guidelines that were a really long time coming. So they were supposed to come out in the fall, and then every month they got pushed back. So they were finally officially released in February. They will replace, they will take official effect as provincial guidelines in a couple of weeks, so June 5th. And we're going to go through these treatment guidelines in a little bit of detail, just because some of the things included in them represent a shift from what we have been doing for opiate addiction for quite a long time. So this is an image that I'm going to come back to a couple of times during the presentation. And kind of it's a nice overview of what these guidelines include. So we can see that there's kind of a scale of low treatment intensity up to high treatment intensity. And then we're going to talk about withdrawal management, agonist therapies, and we're going to spend a bit of time talking about kind of how they work. And then specialist-led alternative approaches, I'll spend a little bit of time talking about. And then what I really like about this image is that harm reduction really occurs across the continuum, so is applicable for all people of all treatment intensities or across the continuum of care. So first, we're just going to talk about withdrawal management. So kind of what is detox or what is withdrawal management? It's kind of an intervention aimed at reducing health harms associated with substance use cessation. So for example, for people who have an alcohol use disorder or are dependent on alcohol, if they stop drinking abruptly, people can be at risk of withdrawal seizures. And so detox for those individuals is really important, particularly if they have a seizure history. They actually should be advised they should go to a detox center and not really do this at home, or they should be admitted to hospital in certain cases because they can die of this. Opiate addiction is uncomfortable, but not, or sorry, opiate withdrawal is uncomfortable, but in and of itself isn't fatal. And so there's no risk of seizure or other things. In the context of this presentation, I'm generally going to talk about detox at a detox facility. So like going to a detox facility where you're there between 5 to 10 days. So is this a good idea for opiate addiction? I can tell you we've been doing it a lot. So I used to work at a detox center in Vancouver, and we would have people come in all the time for opiate addiction, and it would be their 20th time there, and they're like, I want the methadone taper again. It worked last time. I was like, no, it didn't work. Like, you're here for the 20th time. So we need to change the treatment plan. So we have been doing this historically a lot. But what this report from the World Health Organization and the United Nations Office on Drugs and Crime shows is that the period of time right after release from prison or from a detox facility actually poses a significantly increased risk of fatal overdose. So this is concerning. It's important to note that detox can potentially be an important kind of first point of contact for some people, can be a bridge to other treatment options. But when we do it as a standalone intervention, so for someone with an opiate addiction, if that's their only plan is just, I'm gonna go to detox and then I'll be off heroin, that's it. It actually is probably not a good idea, and we probably shouldn't be doing it at all. When we do it as a standalone intervention, what the research shows is that it doesn't work very well. So about 90% of people will relapse. Most of them will relapse in the first week. And what happens is, if they're in a detox facility and they're there for, say, 5 to 10 days, they can lose their tolerance to opiates really quickly. And so if they do relapse, statistically 9 in every 10 people will, they're at high risk of fatal overdose if they return to especially if they return to using as much as they were before. But with fentanyl in the drug scene, it's really unpredictable, and so they're at high risk of death. The other thing that the research shows is that in people who inject drugs, the period of time right after leaving a detox facility, they're actually more likely to acquire HIV or hepatitis C, and this seems to be related to high-risk injecting in that period of time after detox. So this is a pretty big shift from what we have been doing. Some detox facilities on the coast, and we're talking about implementing it at the ones that we have in the interior, are now advising people that really we shouldn't be doing this. If they're like, this is the only thing I want to do, then we're actually having them sign a waiver explaining this is really high risk and has high potential for harm, so that they're really well aware and they've been kind of educated about the risks. Take-home naloxone training for these individuals is incredibly important, and talking to them about the fact they're at an increased risk of overdose and death. So what about residential treatment? And the caveat to this is residential treatment without OAT, so opiate agonist therapy. This has multiple names and it's kind of confusing. So medication-assisted therapy, opiate replacement therapy, opiate agonist therapy, opiate substitution therapy. They all mean the same thing. So it means using methadone or Suboxone. The terminology is shifting towards opiate agonist therapy, and there's a shift away from opiate substitution therapy. And the rationale for that is that a lot of people are like, oh, I'm just substituting one drug for the other. And so we're taking away the word substitution. The research for residential treatment that is available isn't very good. So essentially, we don't have a lot of high quality research to guide us. The research that we do have shows that, again, the relapse rates without these medication options for people with opiate addiction is really high. What we don't know is what are the qualities of a treatment center that are effective for some people, and what are the qualities in a person that makes some people able to obtain sustained remission. So we're not really sure on that literature, and there's a big gap there in the literature. Next, we're going to chat about agonist therapy, and this is really kind of the mainstay of treatment for opiate addiction. So these are using medications called methadone and Suboxone, and both of these medications are medications that act on the opiate receptor and are long-acting. So you generally take them once a day. Suboxone, you can actually give it every other day. But it's kind of hard to remember to take a medication every other day, so practically we usually use it once a day. Both of them work by alleviating opiate withdrawal, helping with cravings, such that when people are dosed adequately on it, individuals generally do not use opiates. And when they're dosed appropriately, if someone were to use heroin or other drugs on top, the euphoria that they would get from that opiate is generally blocked, so they don't get euphoria. So that may be a reason why we titrate someone's methadone or Suboxone, is if they're still getting high on their methadone dose, that tells me that we haven't reached kind of full blockade of their opiate receptors, and so we would titrate up their methadone dose. Methadone's generally given as a liquid once per day at the pharmacy. It's generally given as what's called a daily witnessed ingestion, so you go to the pharmacy every day until you demonstrate clinical stability, meaning generally urine drug screens that are consistently negative for kind of everything you would expect it to be negative for, as well as kind of social stability, so they have stable housing, they have a safe place to keep the medication. The reasons why there's lots of rules around the methadone program are that this medication can be really dangerous if it's diverted. So if someone who doesn't have tolerance to opiates takes it, they can die from it. So that's why there's a lot of rules around this. There's also a lot of rules around how we can titrate methadone. And the reason for that is that if we do it too quickly, people can die. And so that's why there's so many rules with the methadone program. With Suboxone, so the Suboxone's the brand name. It's the two kind of ingredients in it are buprenorphine and naloxone. Buprenorphine is the active ingredient. So it's what's called a partial opiate agonist. So it acts on the opiate receptor, stimulates it partway. This is enough to get people out of withdrawal, to help with cravings, and kind of blocks that receptor. So if they use opiates on top, they don't get high. The naloxone component, it actually, if you take it as it's prescribed, so if you take it under your tongue, the naloxone component does nothing. So it doesn't have good absorption or bioavailability taken under the tongue, or if you swallow the pill. The only reason the naloxone component is in the pill is to prevent diversion. So if you inject naloxone, or if you inject the pill, the naloxone component becomes active and you Narcan yourself. Same with if you snort the pill. So that's the only reason it's in there, is to prevent diversion. I'm not sure why we haven't done this with other opiates. And I think it may be coming to have like morphine and naloxone in the same pill. It seems counterintuitive, but if you take it orally as prescribed, it's not active. So both of these medication options are generally recommended as long-term treatments, and then a slow taper off. And the reason for that is, again, the relapse rates are really high if we treat for a short period of time. So if we treat someone just for a week and then titrate them down really quickly, the relapse rates remain quite high. So generally they're long-term treatments. Everything's individualized. The literature for methadone shows that compared to not being on methadone, so compared to placebo or other approaches, people on methadone are much more likely to stay in treatment, and they're much less likely to use heroin. And then there's also some really interesting research looking at kind of other effects when people are treated with methadone. So looking at decreased opiate use, which is our intent, but also decreased HIV risk behaviors and decreased crime. As well as this is another study looking at decreased crime in people on methadone. And then some interesting research looking at HIV antiretroviral adherence on patients on methadone versus not on methadone. So some really interesting kind of other effects of overall stabilizing someone from an opiate addiction standpoint. Suboxone, it's been available in the US since 2002, in Canada since 2007. These new provincial guidelines are advocating the use of Suboxone as a first-line agent over methadone when possible. Previously, as of a couple of years ago, we had to demonstrate that someone had failed methadone prior to starting them on Suboxone. That's changed. The College of Physicians also recently took away, you used to have a methadone exemption in order to prescribe Suboxone. That changed as of last year as well. Methadone falls into the same category as other opiates. The difference with it is it's really long acting, so it doesn't peak, so people don't get euphoria with it. But it is what's called a full agonist. And so what that means is as the dose goes up, so does the effects of all the opiates, including respiratory depression. So it is possible to overdose on methadone, and that's why there's lots of rules around it, particularly around getting take-home doses, because if someone takes it that doesn't have tolerance, they die. So we need to be really careful with it. What's really neat with Suboxone, it's what's called a partial opiate agonist. And what you see is initially you get more and more of an opiate effect as the dose increases, but then you kind of get this, like, they call it a ceiling effect. So as the dose goes up, the yellow line doesn't continue to go up. It kind of plateaus. And this is what happens with respiratory depression with Suboxone. So even if someone overdosed on Suboxone, they're not that likely to die of an overdose. So it's a much safer medication for that reason. Some of the safety profile of Suboxone, so that ceiling effect, is taken away if you mix it with benzodiazepine, so Ativan, Valium, clonazepam. You can tip someone over into the respiratory depression area if they combine Suboxone and benzodiazepine, so that does take away that safety profile. In terms of Suboxone, as long as it's dosed adequately, so doses at least 12 to 16 milligrams, it's just as good as methadone. But in terms of safety, I'm not going to go through all the studies, but this is from the new treatment guidelines, 6 times greater safety profile than methadone in terms of overdose risk. And this is, I think, the coolest study. So this looked at the French experience using buprenorphine. They've been using Suboxone way longer than we have in Canada. So what they did was, in the mid-90s, they were having this huge rise in heroin overdoses. And they had similar regulations to methadone that we have in Canada. So there's lots of rules, and the rules are kind of there for a reason, because in the wrong hands, methadone is really risky. But what they did is they made Suboxone available that all physicians could prescribe Suboxone, and they really tried to limit the barriers around getting on this medication. And I'll kind of walk you through this picture. So the black bar is the heroin overdoses. So you can see it was peaking, and then it came down. This really hard to see light line is the number of people on methadone. So the number of people with opiate addiction that could potentially benefit from methadone or Suboxone. Prior, not many people were getting on methadone, so because there were all these rules and you had to go to specialized clinics, when they made Suboxone readily available, you can see that as more and more people, so that gray line, were prescribed Suboxone, there's a dramatic decrease in the number of opiate overdose deaths. So pretty interesting. So it's a pretty safe medication, lots of good research showing that it decreases overdose risk. There's advantages to both treatment options. The main disadvantage with Suboxone is that the induction, which is right when we start someone on Suboxone, can be difficult for some people. So they need to be in withdrawal to start it. And the reason why, it's a bit complicated, but essentially you're going from a full opiate agonist if you have heroin on board. And then if you give Suboxone, it's only a partial agonist. So what it does is it's really sticky to that opiate receptor. It punts off whatever opiate's on there and binds, but you're going from a full opiate to a partial opiate, and it's that relative difference that's called precipitated withdrawal, and people feel terrible. So if we give Suboxone when their opiate receptors are empty, it takes them out of withdrawal and they feel great. So we give it to people when they're in withdrawal. The really nice thing is we can get people to an effective dose in like 1, always to maybe in someone with lots of tolerance, 3 days. So we can titrate someone to an effective dose in 3 days. With methadone, it takes probably 2 months to get someone to an effective dose. And the other nice thing is if we start with Suboxone, and it's not working, so in 3 days we get them to the maximum dose, they're like, I'm still using, I hate this drug, whatever. You just stop the Suboxone, you start methadone the next day. Methadone to Suboxone switches are possible, but they're really complicated, and they're much more challenging. So these new guidelines are really advocating start with Suboxone first, switch to methadone if it's not working, because it's much easier than the other way around. This is just some changes that have taken place. So physicians no longer need a methadone exemption to prescribe Suboxone. And despite all this really good research showing how effective these medications are, there remains a lot of stigma around the use of these medications. A lot of the stigma relates to the fact that they act on the opiate receptors. But really, if we think about addiction as being like cravings, consequences, the behaviors that we see when someone are in their addiction, all those behaviors are resolved when people are treated with these medications. So they work really well in treating, like, I think someone's addiction. People will, if you stop taking the medication abruptly with methadone or Suboxone, you will go through withdrawal. And so we have to taper people off of it. And slower tapers are generally better. Similarly, there's many treatment centers and recovery houses that have restrictions on the use of methadone and Suboxone. There are some early conversations happening with an organization called the BC Centre on Substance Use and kind of recovery-based programs that are abstinence-based. And just bringing everyone to the table, going over this literature, I think changes will occur, but they will occur slowly. But people are coming together to talk, and I think that's a really promising start. So in terms of harm reduction approaches, I'm just going to kind of go through a couple different approaches that you may have heard of. The first is just kind of providing harm reduction supplies. So for example, providing clean needles and sharp bins to people who inject drugs, or clean pipes and other supplies to people who smoke drugs. And really the evidence is really clear that doing this decreases transmission of HIV and hepatitis C. And limiting access to these supplies. So in the US, they really are behind in a lot of places in terms of harm reduction. And it can really have devastating effects. So there was a community in Indiana that is a population of 4,000 people. They had 200 new cases of HIV in a year. And this was mainly related to shared injection supplies related to injection drug use. So if we think of the cost of providing clean needles compared to treating infections like HIV and hepatitis C. We've got good treatments for both of them, but it's quite costly, and if we can prevent them, it makes way more sense. In terms of take-home naloxone kits, I'm not going to spend time on this because I think everyone in this room knows a lot about these. So they're there, you know about them. Give them to everyone who uses drugs or people who are at risk of seeing someone overdose. Sometimes I get questions about whether it increases risk behavior, like whether you have a Narcan kit and then that means people are more likely to inject in high-risk ways. The literature doesn't seem to show that. In fact, it shows that when people get training, they're made more aware of the risk of overdose and are safer in their injecting behavior. But anecdotally, I have heard of some kind of youth experimenting in different ways. But I do think in terms of the overall scheme of things, having these kits does a lot more benefit than potential harm. Supervised injection sites or supervised injection facilities. So this is a photo of the supervised injection site in Vancouver called Insight. And what these sites are places where people can inject pre-obtained drugs in a supervised setting. They're provided with harm reduction supplies, for example, needles and syringes and sterile water and alcohol swabs. And then the staff that work there are trained to treat overdoses if they occur. And then the staff can also provide clients with education on safer injecting practices and can also connect people into treatment. So that's kind of what a supervised injection site is. What it's not is a place where you like do drug deals there. So that's banned, like you can't do that. It's not a place where the government supplies you with drugs. And it's not a place, you're not actually allowed, you have to inject yourself. You can't have someone else inject you at Insight. So you do have to be able to inject yourself. That is, there is a patient population who are not able to access Insight for that reason. So they can't inject themselves, so other people inject or fix them. And so with the current rules, they're not able to access Insight for injection purposes. This is just a review of kind of all of the research looking at Insight. And what it showed is overall there's been, since Insight has opened, there's decreased public injecting, decreased syringe sharing, decreased opiate overdoses in the area around Insight, increased safer injecting behaviors, increased connection to addiction medicine treatment, and no increase in initiation into drug use and no increase in drug-related crime. In terms of kind of new things that are coming out, I just thought I'd talk about some things that may be coming to Canada in the next little while. This is actually a buprenorphine implant that goes up in the upper arm that is now available in the US. I don't know how soon it may come to Canada, but it lasts for 6 months. So it goes in the upper arm and lasts for 6 months. In terms of prevention, so I'm a family doctor. Prevention is a big part of kind of the work that I do. The College of Physicians in BC came out with a document in July of last year that's called the Guidelines and Standards. It's been kind of scary because guidelines are kind of recommendations, whereas standards are enforceable, that essentially you have to do this. So what these prescribing guidelines really say is that they recognize that we've really overshot the mark. And in terms of prescribing, we've been over-prescribing for conditions that opiates aren't indicated at high doses for indications where we shouldn't probably be prescribing opiates at all, and prescribing them for much longer than we probably ever should have. And so this is some recognition of that to prevent a future generation of people developing opiate addiction. The previous guidelines said like this kind of watchful dose was 200 milligrams of morphine. These guidelines are saying really 50 milligrams of morphine should be the maximum dose. Because what the research shows is that as you increase the dose, people don't generally get incremental improvements, but you put them at higher risk of harms. In certain situations, you may go up to 90 milligrams if you're really documenting that they're doing well, but you shouldn't really go over 90. And you should avoid prescribing with other sedating medications, in particular benzodiazepines. So this is a pretty big shift in practice. I think there's been some unintended consequences of these guidelines, that people have been cut off their opiates or decreased at a really rapid rate. And I think part of that has stemmed from family physicians being kind of scared. So generally, I think the recommendations in these guidelines are tapering by 10, maybe 15% once a month or less frequently. So it's a gradual shift, and also really screening for if you were to start opiates for a patient for chronic non-cancer pain, making sure that you screen for who's high risk of developing an opiate addiction and who may be lower risk. And then it's not to say that if someone is high risk that you don't prescribe opiates for them, but you have to be really cautious. So you may have them come back more frequently. You may be really watchful of kind of the dose that you're using, and just checking in more frequently. So just to kind of review what we've covered, addiction is a chronic brain disease that affects the reward pathways in our brain. It's treatable, and we've got lots of treatment options, in particular for alcohol and opiate use, nicotine use, stimulant use, less so, but there's lots of research. We have a lot of science to the way that we, to support the way that we should treat it, but it's not always being implemented. And if one treatment option doesn't work, we should try something else, like we would in any other area of medicine. In terms of next steps, we'll go back to this article from 1919. So this physician, this wise physician 100 years ago, said, as a definite clinical entity of physical disease, addiction is practically untaught in school and unappreciated by the average medical man. The medical profession has, as a whole, ignored the subject as a clinical study or laboratory investigation. And I think we're still pretty close to this. I think that we're studying it a lot more, but we're not teaching it very well in medical school or in residency. So family physicians, despite seeing this like alcohol addiction all the time, we're not taught a lot about how to treat it. And then opiate addiction, we're not taught that much about how to screen for it and how to treat it routinely. The hope is that this is changing. So in BC, I think we're really fortunate to have some really good leaders who are very passionate about improving access to training for addiction medicine. So there's a one-year fellowship program in Vancouver. There's hopes that, and there's a nurse practitioner, I don't know if he's here, is Zach? No, he's coming tomorrow, I heard. So Zach is actually doing it. He's a nurse practitioner from Nelson who's doing the one-year fellowship starting in July, so in a month. So it's great to have someone from the region who will come back and I think be a huge asset to the community. Not that he isn't already, but yeah.
So will you be able to prescribe Suboxone?
Yeah, it's changing. So as a nurse practitioner right now, you can continue Suboxone if someone else has done the induction. It will change, I think, within the next 6 months for sure, that nurse practitioners will be able to do an induction for Suboxone as well. And likely the next step will be to look at prescribing methadone. So I think that will be coming as well for nurse practitioners in the conversations I've had, yeah. So lots of areas for improvement in terms of education. And then again, approaching addiction as a chronic disease, not kind of these short little bursts of treatment. And a relapse is an opportunity to intensify treatment, not to just push the same treatment option. And that's it. Question. I'm not a cat person, but I really like this slide.